Hey everyone, welcome back to the channel. Or if this is your first time here, a massive hello and thank you for tuning in. Today we are going deep, really deep, into one of the most researched and talked about compounds in the performance and medical worlds. Ostarine, also known as MK-2866 or Enobosarm. We are talking a full evidence-based episode packed with clinical data, real numbers, mechanisms explained simply, benefits, risks, practical guidance, and exactly who this compound was designed for. By the end, you will have a complete science-backed picture. So, grab a coffee and settle in. Let's get started. First, let's set the scene properly. Before we zoom in on Ostarine, we need to understand what SARMs actually are and why they were created in the first place. SARMs stand for Selective Androgen Receptor Modulators. Now, I know that sounds like something straight out of university lecture, so let me explain it in plain English. Your body has androgen receptors, tiny docking stations on cells, especially in muscle and bone, that respond to hormones like testosterone. When testosterone binds to these receptors, it triggers muscle growth, bone strengthening, and other anabolic effects. Traditional anabolic steroids, the ones you might have heard about from bodybuilding history, activate this receptor everywhere in body. That include prostate, skin, hair follicles, and even the brain. The result? Great muscle gains, but often unwanted side effects like prostate enlargement, acne, hair loss, or voice deepening in women. SARMs were invented to solve exactly this problem. They are designed to bind selectively, primarily to receptors in the muscle and bone, with far less activity in other tissues. The idea was born in the late 1990s. Scientists at companies like GTX Incorporated wanted medicine that could treat serious conditions, muscle wasting in cancer patients, age-related frailty, osteoporosis, without full steroid package. Ostarine or Enobosarm emerged as one of the most promising candidates after years of chemical tweaking. It's an oral, non-steroidal compound with excellent bioavailability, meaning your body absorbs it efficiently when you take it as a capsule or liquid. And here is why it matters today. Even in 2026, Ostarine remains the most extensively studied SARM, with data from over 27 clinical trials involving around 1,500 people. Doses from 0.1 milligram right up to 100 milligram in some safety studies. With that foundation laid, let's get into science. How does Ostarine actually work inside the body? Once you swallow it, Ostarine is absorbed quickly and bind to those androgen receptors I mentioned, but with a strong preference for skeletal muscle and bone cells. This binding changes the receptor shapes, allowing it to travel to the cell nucleus, where it acts like a genetic switch, turning on genes responsible for protein synthesis. In simple terms, it sends a clear message to your muscle cell: build more protein, repair faster, grow stronger. Importantly, unlike testosterone, ostarine is not converted by enzyme 5-alpha reductase into more potent dihydrotestosterone, which is what drives prostate and skin issues. It also doesn't aromatize or convert into estrogen. That dual avoidance is a big part of its tissue selectivity. Researchers also observed effects on insulin sensitivity and fat metabolism, possibly through both genomic, gene level, and some non-genomic, rapid signaling actions. In animal models, it has shown the ability to preserve bone mineral density during aging or after hormone loss. The half-life is around 24 hours, which means blood levels stay stable with once daily dosing, making it convenient compared to some other compounds, SARMs or oral steroids. Mechanism covered. Now the part everyone wants to hear. What does the actual clinical evidence say about the benefits? We are sticking strictly to published trial data, not anecdotes. Let's start with the landmark Phase 2 trial from 2011 by Dalton and colleagues, published in Journal of Cachexia, Sarcopenia and Muscle. 120 healthy men over 60 and postmenopausal women received either placebo, 0.1, 0.3, 1, or 3 milligram every day for 12 weeks. At the 3 milligram dose, participants gained an average of 1.25 kilogram of lean body mass. That's a statistically significant 3.1% increase from baseline, while the placebo group actually lost 0.7 kilograms. They also showed measurable improvement in physical function, including ester climb power, and a 27% improvement in insulin sensitivity. Fat mass dropped by 0.32 kilograms at the highest dose. Now, move on to a larger cancer cachexia trial, a Phase 2b study with 159 patients suffering from muscle wasting due to cancer. After up to 16 weeks, the 1 milligram group gained 1.5 kilogram of lean body mass. The 3 milligram group gained 1.0 to 1.3 kilograms, while the placebo group gained only 0.1 kilogram. Ester climb power also improved significantly in the active groups. Fast forward to more recent work in 2024 and 2025. Vero Incorporated, who now holds the rights, ran the quality trial combining Enobosarm with semaglutide, the popular GLP-1 weight loss drug, in older adults with obesity. Interim data showed an absolute increase of 1.5 kilogram in lean mass in Enobosarm group versus placebo, while achieving even greater fat loss. This is huge because GLP-1 drugs like semaglutide often cost 20 to 40% of total weight loss to come into muscle, which ostarine appear to blunt dramatically. A separate 2024 Phase 2 trial in androgen receptor positive, estrogen receptor positive, HER2 negative, advanced breast cancer showed a clinical benefit rate of 30 2% at 9 or 18 milligrams daily, with acceptable progression-free survival. At the higher recreational doses commonly discussed online, 10 to 25 milligrams per day, user logs and aggregated data often report lean mass gains of 2.7 to 3.6 kilograms over 8 to 12 weeks, especially when paired with resistant training and a modest calorie surplus. Many also note improved muscle preservation during cutting, faster recovery, and better muscle hardness. Additional preclinical and early human data suggest benefits for bone health, with increased mineral density in osteoporosis models, and potential help for frailty in elderly. So, the numbers are clear. Ostarine can meaningfully increase lean body mass, support physical function, and help preserve muscle during calorie deficits or medical stress. But this is crucial. No compound that affects hormone pathway is without risk. Let's talk honestly and in detail about the side effects. At the low clinical doses of 1 to 3 milligrams, the safety profile in trials was relatively good, with many side effects matching placebo. However, at the higher recreational doses and with longer use, the picture changes. The most consistent effect is suppression of natural testosterone production. Ostarine can reduce luteinizing hormone, LH, and follicle-stimulating hormone, FSH, leading to lower endogenous testosterone. In men, this may show up after a cycle as fatigue, reduced libido, or mood dips, which is why post-cycle therapy, PCT, is commonly discussed. Studies at higher doses have shown clear hypothalamic pituitary gonadal axis suppression. Liver health requires attention. Transient raises in alanine aminotransferase, ALT, have appeared even in trials. In real-world case reports, recreational use has been linked to cholestatic liver injury, sometimes severe enough to need medical care, though these usually resolve after stopping. A systematic review of SARM safety highlighted drug-induced liver injury as a key concern, especially with untested products. Lipid profiles often shift. In the original 3 milligram trial, high-density lipoprotein, the so-called good cholesterol, dropped by up to 27% in a dose-dependent way. Other reported effects include mild headaches, nausea, back pain early on, fatigue, or in user surveys, reduced testicular size and acne when used beyond 3 months. Rare but serious cases of rhabdomyolysis have been noted when combined with intense training. Importantly, because Ostarine is not approved by MHRA, FDA, or EMA for general use, products sold online are research chemical of unknown purity, often contaminated or underdosed. That adding extra risk. Bloodwork during and after in any dosage and cycle lengths is non-negotiable. We've covered the science of how it works, what it can do, and what can go wrong. Now let's get practical. How do people actually dose it, structure cycles, and use it safely? First and foremost, this is educational information only. Ostarine is not approved for human consumption outside clinical trials. Always consult a qualified doctor and never self-medicate. In clinical trials, doses of 1 to 3 mg per day produce the benefit we discussed. In the recreational context, the most commonly reported effective range is 10 to 25 mg daily, taken once per day thanks to the 24-hour half-life. Beginners usually start at 10 to 15 mg to assess tolerance, while more experienced users might go up to 30 mg, though higher doses increases side effect risks. A standard cycle is 8 to 12 weeks, followed by an equal or longer break or a structured post-cycle therapy to help restore natural hormone production. Common PCT options discussed include selective estrogen receptor modulators like Clomid or Novodex for 4 to 6 weeks, with dosing tapered under medical supervision. How to use it? It's taken orally, with or without food, at the same time each day for steady levels. Pair it with a solid training program, progressive overload, and nutrition, aiming for 1.6 to 2.2 grams of protein per kilogram of body weight. For cutting, keep calories in moderate deficit. For bulking, a slight surplus. Monitoring is essential. Get baseline blood work, then again, at weeks 4-8, check total and free testosterone, LH and FSH, estradiol, liver enzymes, ALT and AST, full lipid panel, and a complete blood count. Many users also track prostate-specific antigen if male. For stacking, some combine it with other SARMs or compounds, but this multiplies risks and is not recommended for beginners. Legality note for UK listeners: Ostarine is a prescription-only medicine and a controlled research chemical. It's not legal to sell for human consumption, though personal import for research is a gray area. It's banned by WADA for athletes, so competition use means a positive test. So, who was Ostarine actually developed for? And who might consider it today? Originally, the target was medical population with serious unmet need. Cancer patients suffering cachexia, when muscle wasting dramatically reduces quality of life and survival. Elderly, with sarcopenia, an age-related loss of muscle and strength. Postmenopausal women and older men at risk of osteoporosis, where preserving bone and muscle could prevent fractures. More recently, trials have explored its use in androgen receptor-positive breast cancer and, excitingly, in older adults on GLP-1 weight loss drugs to prevent the muscle loss that often accompanies rapid fat reduction. In the fitness community, it attracts athletes and bodybuilders seeking a milder alternative to traditional steroids, especially during cutting or body recomposition phases, where the goal is fat loss without sacrificing heart and muscle. Women sometimes report using lower doses, 5 to 10 milligrams, finding it more tolerable than many anabolic options. That said, it's not for everyone. Competitive athletes risk bans. Young, healthy individuals with no medical need face unnecessary hormonal and organ stress. And anyone with pre-existing liver, heart, and hormone issues should stay well clear. There we have it, a truly in-depth evidence-packed look at Ostarine MK-2866. From its selective mechanism through clinical gains of 1 to 1.5 kg of lean mass in trials, to the very real risks of suppression or lipid changes and liver concerns, and right through to practical cycling and target uses. The data shows genuine potential, particularly for medical muscle preservation, but it's no magic bullet, and it's not risk-free. Responsible decisions, proper medical oversight, and thorough blood monitoring are absolutely essential. If you found this deep dive valuable, please hit that like button, drop your thoughts and questions in the comments, and subscribe so you catch every future episodes on performance science and evidence-based health. Thanks so much for spending this time with me. Stay curious, train smart, look after your health, and I'll see you in the next one. Take care.